I'm
Oh, there you
recording.
go. Okay. All right.
And Rebecca Bixby is going to be speaking for part of the time because she's going to talk about the update on the prescribing module and the updated version.
Okay.
Okay, so I'll let you know when it's time to unmute her, but I don't
Okay.
see her on yet. So hopefully she'll come on soon. And we only have 3 people right now.
And one of them is Suzanne.
Yeah.
I'm just going to start, I guess, and I'll just say that we're going to give folks a couple extra minutes to get on.
Okay.
Is that okay?
Mm-hmm.
All right, I'm going to start the broadcast.
The broadcast is now starting. All attendees are in listen-only mode.
Hi, everybody. This is Holly from the Health Federation. Just wanted to say thank you for those of you who have joined us already. It is 1 o'clock right now, but I think we're going to give folks just a couple of extra minutes to get on since we only have a few people here so far. So if you'll just bear with us for a couple of extra minutes, we will get started shortly. Thank you.
Holly,
Yes.
are you seeing just the slide up or are you seeing the presenter view?
It looks like the presenter view. I think we could see the next slide if that's what the presenter view is. Okay.
Mm-hmm.
All right, I think we'll give folks just like 2 more minutes and then we'll get started.
Are you now seeing the slide view?
Yes, it looks like it.
Great, thanks.
All right, I think we will get started. Good afternoon, everybody. Thank you all for joining us for today's GE Centricity User Group call. All attendees are muted automatically upon joining, but we'd like to keep this as interactive as possible. So if you'd like to make a comment or have a question, please feel free to enter it in the chat pod over on the right-hand side of your screen, or raise your hand so you can be unmuted. Today's call will be recorded, and both the recording and the slides from the presentation will be available on the Health Federation's HCCN project portal by the end of the week. So I'll let Deborah McGrath, our Director of Health Information Technology at the Health Federation, take it from here.
Hi, everybody. Great to have you all again for our GE Centricity User Group webinar. We are going to, today's agenda includes looking at medication reconciliation and how to make sure you're getting credit for that for meaningful use. Using sort of a brush up on the SureScripts history medication module again. We're going to talk about the new prescribing module that is in the version 12.2 of CPS. Some of you, this may not be applicable if you haven't upgraded yet, but at least you'll get a look at what the upgrade looks like. We're going to talk a little bit about SOGI and how to stack the deck in your favor to make sure you're getting that SOGI information that you need for UDS. And then I would like to open up and talk about any support issues that you might be having. I've become aware of a few over the last little while, and just wanted to have a little bit of a forum in terms of how that's going for you and how we can give some feedback to GE about that. And if there's anything else that is absolutely a burning issue for you, go ahead and put it in the chat box or questions, and Holly will be sure to sort of stop me and make sure that we get it done, because I think we'll get through this information in less than our hour-and-a-half allotted time today. So it's come to my attention that some of you are struggling with getting your numbers for meaningful use attestation on the med reconciliation piece. So what I did was I went back to the documentation in Centricity with an attempt to kind of distill that out for you and help you to see what you need to be doing to get this credit. Now, one thing that may be a little bit confounding on all this, and I found this in the GE documentation, is they're pretty much focused on MIPS and MACRA, which are, as you know, the part of the CMS quality pieces and not part of meaningful use for Medicaid. So it may be that we need to make sure that your CQR is properly configured and picking things up properly, because the bar is quite a bit lower on the MIPS and MACRA end of life than they are for meaningful use. So the med reconciliation objective for meaningful use for Medicaid states that you are to perform medication reconciliation for more than 50% of transitions in care in which the patient is transitioned into the care of the eligible provider. So that means that patients are only going to get counted in the denominator if they're in a transition of care, and that is defined as first encounters with a new patient and encounters with existing or established patients where a summary of care record of any type is provided to the receiving provider. So if you're getting something from a referring provider to you, or if you indicate the transition of care, that is a small checkbox. I'm going to show you a screenshot in a second, at the start of an update or at the end of the update. But please note that if it's a patient's first visit with you, if they're newly registered in Centricity, it is automatically counted as a transition of care event, even if that box is not checked. So the box that we're talking about is this one here that I've got highlighted in yellow. So this dialog box, as many as you know, pops up at the beginning of an encounter or at the end of an encounter. And it doesn't matter where it is counted as a transition. It just needs to be counted as a transition in order for that patient to be included in the denominator. Now, I think one of the things that I wanted to just sort of point out is I'm wondering if providers always know, or if medical assistants always know, that in fact the patient is in a transition of care situation. So I think there's you're probably going to need to be thinking about some of your workflows around how the person in the clinical area knows that this patient is in a transition of care situation in order to get this box appropriately checked. The numerator is one count for each medication reconciliation that is performed. And for those of you who are paying attention to observation terms, it's this value, meds reviewed, and that's the observation term, and the value is done. That value is case sensitive, so it has to be a capital D, an O, and an N, and an E in lowercase. And you've got to make sure that the CCC basic clinical kit is installed. So those three things are required, or those two things are required. So making sure that medication, that meds reviewed is the actual observation term that's being picked up when you do the meds reviewed is important. Otherwise, you're not going to get credit for it. The workflow. The first thing you want to do is you want to check the desktop messaging tab, and that's where you're getting messages in from a referring provider. I don't think that happens all that often for you guys, although it may start happening as you you get your health information exchange working, and that you begin to receive documentation from hospitals who may be referring to you. And then it gets saved as a transition of care document to the patient's chart, which again triggers that this patient is in a transition of care situation. And then you will look and see and I'm going to show you some screenshots, so don't worry, we're going to take a look at this. So if there are any clinical changes to reconcile, you will review them and address them when you open the patient's chart. Or you mark this encounter as transition of care at the start or the end of the update, as we just talked about, and check meds reviewed. The clinical reconciliation form is included in this new CCC Basic Clinical Kit, and it's accessible from these areas: CPOE, A&P, HPI, problems, and the Meaningful Use Core Checklist. So this is the reconciliation button that we're talking about. This is the CPOE form. It's down here on the right on that problem CCC form, which I don't think many, if any of you are using. It is here. Oh, I'm sorry. Back up a second, Deb. This is the HPI form, and many of you are using this, so that's where you'll find it. This is the problems form, and it's located right here. And then on the MU checklist, it's located under problems, medications, and allergies. And in this case, what we're concerned about is the medications reconciliation. When you click that button, this is what you get. You get the option of being under problems, allergies, or medications. When you click these, and you do have to click each one, so people will start counting mouse clicks and talking to you about it. You can then make any adjustments to that medication from that place, And then this med review, mark reviewed will pop up, and you can click it there, and that gives you credit. So using that reconciliation button on any of the forms that we just talked about, and then click on medication and mark as reviewed. Alternatively, you can click here. And I'm sorry, it's incomplete in my little note here, but when you click here, you note that this patient's only going to be added to the numerator and denominator if this is a transition of care situation. So this is the patient's, as you recognize there, that chart summary screen when you come into the chart. So we'll push the pause button here a second and see if there are any questions or concerns about this, about the med reconciliation piece.
If you have any questions or comments, please feel free to enter them in the chat pod on the right-hand side of your screen, or raise your hand and I can unmute you. It looks like we have a comment from Primary Health Network. It says, at Primary Health Network, incoming transitions of care go directly to chart from Qvera. Our messaging window is not set up for use. We have a separate MedRec form but have not really implemented yet.
And Sherry, I would ask, are you guys doing okay with the med reconciliation piece for meaningful use?
Sherry, I'm going to unmute you if that's okay.
Sure.
You're unmuted.
Yeah, okay. Yeah, being I don't run those, I would have to ask how our numbers are for that. And I can do that while you guys are talking. We actually know about that GE reconciliation piece, but it wasn't working well. We did get a separate MedRec form, just reconciliation form in general for the transfer of care from Qvera Med Allies, but that's been a very big struggle to even get that, or even determining who should be doing it. We're really not doing it, but let me see if anybody's free over here while you guys continue talking that might be able to address this better than me.
So one of the reasons I included this in the discussion today is because I've been getting some feedback around folks just struggling to hit their numbers on this. And like I said, the bar for MIPS and MACRA is one patient per provider, whereas for meaningful use for Medicaid, it's 50% of all transitions of care. So basically, it's a proof of concept for the MIPS and MACRA, and for the rest of us, it's at 50%. So it's a little bit harder to hit this if we're not paying attention to the workflow around it. Or how could we be doing better at it by just, coming up with a workflow that might work. I know that Family Practice and Counseling Network is in the process of implementing Qvera, and Esperanza is also in the process. I think they're in testing phases right now. I don't know, Stuart, you have anything to add or share to this conversation? He just raised his hand.
Stuart, you're unmuted.
Yes, I am. Thank you. Not in terms of medication reconciliation. We're mainly looking at like CCDs, and that does seem to be working. We have a few hiccups with just getting the flags sent to the proper provider when they come in. But the this process started probably over a year ago. Deb McGrath was able to show us, set up a demo that I believe she was doing with another clinic, and everything that we were shown is now functional in our system. We are just a little curious about how we're actually going to promote this, I guess, is the best way to explain it, how we're going to get people to send us the CCDs. Because right now we're using HSX to pull in a lot of our data, but I don't quite know what the workflow will be for getting other organizations to start sending us CCDs other than, you know, the government putting a stick to them and saying they're supposed to be doing it.
Yeah, you're published in the in HSX's directory, Stuart. So for the people that are capable of doing it, they should start flowing. If you are identified as the patient's primary care provider, or the organization can identify you as the primary care provider, then they should start flowing from those organizations that have the capability.
Then that might be our issue, because we currently have 2 HISPs and 2 sets of direct addresses because of how we had to go into Qvera. And Qvera was not able to work with our SureScripts direct addresses, so we had to create new ones with MedAllies. So that may be the reason if HSX has the wrong address published.
Correct. I think you hit the nail right on the head.
Perfect.
Yep. Yep. Great. All right. So we'll keep. I'm going to try to keep track of this, and if and understand how everybody's doing with this, because like I said, the bar is pretty high on the medications. And Stuart, the medication reconciliation should work the exact same way in Qvera, using the Qvera screens to reconcile those meds. So I would ask that you keep an eye on it for those of you using Qvera, to make sure that you are that it's hooked up properly to CQR. So let's keep an eye on that. Any other questions, concerns about MedRec? Okay, moving on. I'm going to beat the drum of SureScripts medication history. Some of you use it, some of you may not be using it, or some of you see it used sort of sporadically in your organization. It is a useful tool when a patient is, for example, new to your practice, and it can help you get a jump start on that active medication list. It may be very helpful for patients that you haven't seen in a while, for patients who have had contact with multiple specialists or hospital stays since the last time you saw them, for patients who are not necessarily reliable historians, and I say that in no judgmental way, but we all know that some people do better at this than others. And also for patients for whom they specialist manages their chronic conditions such as diabetes or hypertension. So if there have been changes to insulin or changes to diabetic meds that were done by the specialist, and somehow you're not getting that information, the SureScripts medication history can be really helpful. So the way that it works is from the medication module, you can click on that. And let me just go back a couple of slides here because I want to show you. It's also available to you with this little clock with the arrow on it is the med history button from the patient's summary screen. You can get to it from here or from here. It then brings up this dialog box. Now there's a couple of things to be thinking about on here. For starters, the patient does have to consent specifically to allow you to run a med history on them. We strongly recommend that you include it in your overall consent for treatment so that patients are basically opting out of this, and you can, unless there's a note on their directives that they have said you can't do a med history, you'll know that you can do it. And for the most part, I think your patients will be fairly compliant with it. You then can request a med history. You can either do it from a date range or just request it, and it will fill in from the last time that you did it. Once you click that, it will bring in these medications from the prescribing network. Now, this is the thing that often takes some time, which is why we do recommend that you think about having this process initiated by a medical assistant so that when the provider comes into the room, this box is populated. You then can select the medications, and it will allow you to add them to the current meds. So when you highlight it, it then makes it possible to add it to the current med list if you choose to. If you don't feel like you need to, or nothing on this list is something that you want on the patient's med list, then it's perfectly fine to just leave it be. This also gives you information as to when this was last recorded. Okay, so in this case, this was last done in July of 2015 at 9:26 in the evening. So it gives you an idea of how long it's been since the last time the med history was gathered. So you could create some protocol that if it's been done in the last month, don't worry about it, but if it's been more than 3 months, you want to do it. I think that's an individual choice and can be done by policy in your organization. But it does give you the meds that have been prescribed by other providers. So I think it can be very helpful and very useful for you. Now, we have had some feedback that in other systems, not in Centricity so much, but in other systems, that there's been a problem with Keystone patients. So if anybody's having those kinds of individual issues where if the patient has a particular insurance, they're struggling to actually get the med history, then please be letting us know. Okay, so I'll pause here and see if there are any questions, concerns about this particular piece. Seeing no questions. Okay, so now I'm going to turn the presentation over to Rebecca Bixby from Family Practice and Counseling Network. They have recently upgraded to 12.2, and she's going to go through the nuances of the new prescribing module. So Rebecca, you are unmuted, and I'm happy to advance the slides for you. So just let me know.
Okay, thanks, Deb. Can you guys hear me?
We can hear you, yes.
Fine.
Okay. I don't know how many folks have already upgraded, but we did put together a workflow for our providers to follow along with the changes made to the prescription refill module. And the major change is that this is now an HTML form. And I think that's a direction that Centricity is headed in general. Deb can back me up on that. But the format does look different, and there is some new functionality. So one of the new features for us that we were not utilizing before is this RX Renewals tab on the left-hand side of the screen under Chart Desktop. And from that tab, you can directly access refill requests coming in from pharmacies. I should add there's a piece of this that is not included in my presentation that is your interface management and vendor management through ours is ESM console. Is that for everyone, Deb? I'm not sure.
Yes, it is. That's for everyone. That's for everyone, yeah.
Okay, so my understanding is there's multiple settings that need to be adjusted there at a provider level to be sure that refills are flowing into Centricity for you if you want them to. You can also set it so that you do not receive direct requests from pharmacy. So that would be something to work out with your IT department before going live with this. Okay, you can go to the next one. So when you click on the refill prescription button at the top of the Centricity chart, this is what would pop up instead of the form that we were used to seeing before. It opens similar to the immunization management window in an HTML pop-up window. And it overall, I think, has a cleaner look. The other major impetus behind designing the form per GE is that the user can navigate more easily on this form. There's a lot of direct links on here that weren't available on the other form, and the intent is that you don't have to leave the page to investigate problems, appointments, things like that. You can do it all from this one window. So on this slide, what's highlighted is in the upper left-hand corner, there should be a pharmacy populated there. If this is entered into the patient's registration information in the registration module, that's what will appear here. If under contacts you have a pharmacy preloaded, and that is, I think, the best practice. It makes it much easier for the providers if the patients are asked what is your preferred pharmacy at registration at the front desk, and it's entered in the registration module, and that it will come straight through to here. If not, the providers can add from that window under the Edit Pharmacy. And that field, one thing that we realized after we went live, if there is no pharmacy populated in that box, none of the medications will be available for renewal, and the renew buttons will actually be grayed out. So a lot of providers called IT saying it's not working, but it was because they hadn't selected the pharmacy yet. That has to be the first step. So right underneath that current pharmacy is the list of active medications, and you, the provider or the RN, would just click on those renew buttons next to the active medications that are being requested, and they then move over to that right-hand side of the window after they're clicked. So I think you can go to the next slide, and we'll talk more about that.
If I can get the laser pointer to go away, I will be happy to do that. There we go.
Okay, so this actually goes back to the RX Renewals tab, where you would have an overview of all the refill requests, and per Centricity terminology, a new refill request, you can see there's a red sort of pink shaded box over where the cursor is right now. Oh, that's my cursor. Never mind, you can't see it. There it is, laser pointers pointing to it. There's a column for new and a column for pending. New means direct request from pharmacy. Pending means it's a renewal that has already been initiated within Centricity. And that should also be accessible under your documents. It'll appear as a document if it was generated from within your Centricity system. It will only appear here in the RX Renewals tab if it's a request directly from pharmacy, in which case it will not generate a renewal document under your Documents tab. So this is a little confusing, but essentially the difference between the new and pending is one is already sitting in your chart, and there's already a pending encounter that you can pick up by clicking the white chart, the open chart to the right there. And then if it's brand new from the pharmacy, you actually want to start the refill document, in which case you would check the black chart. So that's some distinction that for some providers was a little tough to get the hang of. But one is for initiating a new refill, the other is to pick up a refill request that's already sitting in your documents, but it's accessible from this tab.
May I ask a question, Rebecca?
Mm-hmm.
The concept behind it is to kind of give you a dashboard of all of the refill requests that are coming to you as a provider. Do I have that right?
Correct.
Okay. So the Siping Lee at the top is the provider, and then this is so that allegedly from this dashboard you can manage all of the refill requests coming into you. Is that what the intention is?
Correct. And then the other suggested workflow, which we do not use currently, is that a nurse could manage these RX renewals tabs by provider. They would just go to this RX renewals and then select the provider up there in the left-hand corner, and they can change it from one to the next and manage their entire list of refills.
Gotcha. So if you, and does that require that you designate a delegate on the ESM console?
I don't believe so.
Okay.
So I guess you could do both, because that would affect the authorizing provider settings.
Yep. And it would,
That's
it would probably,
actually, that's something I'm going to look into.
Yeah. Okay. I'll help you look into that too.
Thank you. Because that is one issue we're having with the form, is the authorizing provider gets reset every time.
Gotcha.
Okay, do you want to move to the next one?
Yep.
So this actually is a mini workflow within the refill workflow of how to set the list of providers that any delegate would use, and this is done using the My Folders feature of Centricity. I'm not sure if people are familiar with it, but essentially in any drop-down list that has binoculars next to it, you can click on the binoculars to search, and then at the bottom of that box that pops up, you click on More, and that lower window appears where you can select from the larger list. Like, for example, we have 22 prescribers, and one delegate might not be needing to manage all of those. They would only be managing 2 providers. They can just select the 2 providers they would be managing and limit their drop-down in this RX renewals form, if that makes sense.
Yeah, okay. All right.
We could go to the next one. And that's a feature that can be adjusted in a setting that can be used on any drop-down, but it's handy in this RX renewals form. When requests come in directly from the pharmacy, there may be a patient mismatch, and this, I think, used to be in link logic errors, but now it comes through directly to the RX renewals tab or dashboard, and you can actually resolve the error directly from the chart. So you see that little broken lock or broken chain on the left-hand side of the screen. That means that something's not matching the date of birth or the name, and then you can resolve it yourself by going over to the patient search icon and looking up the actual patient in your system, or if you want to send it back to the pharmacy, you can deny the request. You can go to the next one. This is sort of the progression of windows that you would see once you do hit a med for review. It's similar, or for renewal, sorry, it's similar to the former refill prescriptions tab, where you can edit the details by clicking. There's a pencil icon next to each medication, and then you would go in and adjust the quantity, the instructions, if brand is medically necessary, and then there's a second pencil icon for editing the method and the authorizing provider, which is the smallest window all the way down there. It's hard to see.
Yeah, this one down here.
Yeah. What were you going to say?
Are you using the e-prescribing for narcotics?
We are not yet.
Okay.
We're going to introduce, I believe, the key system for two-factor identification probably within the next month or two, but we're not yet. So one thing I will say that providers have noticed is the authorizing provider and the method have to be selected individually on each medication, whereas before there was the ability to select from a drop-down at the bottom of the page, and that would apply it to all the medications. So in some cases, it slows down workflow. If the authorizing provider is incorrect, it needs to be individually changed on each medication that's being requested. And that, I believe, is part of the workflow for two-factor authentication and the new EPCS guidelines, that each medication has to be edited individually. You can't apply changes to a whole list at a time.
Right. So
even if it's not a controlled substance.
Right, right. So this is actually a rule that's been imposed upon the vendor. It's not necessarily their idea of, well, we'll make this easier.
Right. So that's been, I think, the one drawback or where people have gotten slowed down is with that. But hopefully, I don't know if setting up delegates would help that.
I think it would.
We actually had a question.
Sure.
We had a question come in. I don't know if now's a good time to ask it. The question is, can you go live with CPS 12.2 without the EPCS?
Yes, we did. Or without this form, probably both. But we're waiting on the EPCS part, but we went live with this new workflow for everything else. And we're continuing to prescribe narcotics the way we were before.
So the answer is you can't go live with 12.2 without using this form. Is that correct? That's my understanding. You can't keep the old. Can you keep the old?
I think you can.
Renew. Okay. I will get the answer, the definitive answer on that one for everybody. Okay. Any other questions while we've paused?
It doesn't look like any are coming through.
Okay.
This is another feature. When it is a refill request, when it's pending under your documents for edit in the chart, it'll have a little pill bottle icon. So that is a visual cue to show that there's a pending refill for editing.
And that's a pending refill from the pharmacy, is that correct? Or is it that the medication itself is up for renewal?
I think it's any pending refill prescription.
Okay.
Whether internal or an external pharmacy request.
Okay. All
right. So once you've gotten through those steps of editing your prescriptions and the medication information, a box appears at the bottom and it says sign RX now. So it's very bright and bold, which is nice because on the old form there was no sort of enhancement of reminding you to sign. So that's how that appears, and that would push them immediately.
Okay.
Go to the next
and
one.
Then this is where the two-part authentication will come up, right?
Correct. Right. When you go live with the two-factor identification, it would also come up here. So these are the toggle buttons at the top of the screen. The first is the update medications window, which you're familiar with. That's the same one that you can view now. when you go into update meds, and Deb showed us the med history button is on there too. You get to show scripts.
Mhm.
The next one is a list of inactive medications. And the next one is also a list of problems. So these are nice because it doesn't open another window that you have to then close out of. And for problems, you can just hover over and it will show you the list right in the form. Same with allergies. It just shows you right in the form any documented allergies. And oops, I guess we didn't have a close-up of appointments, but actually appointments is the most exciting one because that's something I've never seen in Centricity. So if you go back for a minute, Deb, sorry about that.
No problem.
I'm missing the screen for appointments, but it would show up the same way if you hover over View Appointments. There would be a drop-down of their last appointment and their next appointment. And I think that's a really nice little feature that they could put on other forms too, which would be helpful.
Yeah.
And then the other two are just major interactions and a list of the pending prescriptions. So this is to show a non-matching medication. There is a very small red question mark above that red arrow, and that icon indicates that there's a discrepancy between what the pharmacy is requesting and what was originally prescribed. And it could be a generic switch or maybe a different dosage. So that little red question mark will indicate that there's a non-matching medication request.
Oops.
I think that's it.
Yeah. All right. Any questions, concerns? Anybody else who's using this who would like to talk about how it's going?
Stuart, if it's okay, I'm just going to unmute you again so you can ask those questions.
Thank you. Have you had any obstacles? I know you didn't go live with the e-prescribing of controlled substances. What are some of the hurdles that are keeping you from going live with that, or obstacles?
At this point, I think it was just deciding which method we would use. There's different hardware available in terms of whether you're going to use a key system or there's a few other ways to enter in codes. So just deciding which system we were going to go with, and then also training. And we decided not to do it all at once with the upgrade since it will involve some additional provider training, and we just wanted to space it out. So that's why we're putting some buffer time in between the upgrade and then going live with the EPCS.
Which two-factor authentication workflow did you end up going with, and why?
Well, that's a great question. We actually have not officially decided we'd be going back and forth. So I think the factors that we're batting around are price and then provider preferences. So people are going back and forth on that stuff. We're still in between.
Just for everybody there are two ways of doing it. One is with a key fob and the other is with a phone app. Do I have that right, Stuart and Rebecca?
Yes, that sounds right.
Yes.
Yeah. So, and there are some costs involved with both of them. Anything else, Stuart? Do you have other questions?
No.
There we go. There you go. You were muted there for a minute.
That's all I have.
Okay, great. Anybody else? Any other questions? Not seeing any come up. Okie doke. All right, thank you so much, Rebecca. It's very helpful to hear from somebody who's on the front lines of this, using it. Your perspective is very, very helpful.
Thanks.
All right, so moving on to the SOGI piece. So I think some of this is, you know, all of you know this, that our lesbian, gay, bisexual, and transgender patients are often invisible in our practices for lots of different reasons. And there's, of course, we have been asked to collect this data now for our UDS reports, and some folks have been having some questions about how to move forward with it. What we can tell you is that the SOGI questions, which I'm going to display for you in just a second, have been found to be acceptable to health center patients from a diverse background. The folks up in Boston did do a study on this of over 300 patients from a variety of backgrounds, from Chicago, from New York, Boston, also from, I believe it was North Carolina. And these were people that spanned, you know, the lifespan, as well as people who were gay or straight. It didn't seem to matter. They felt that the question was easy to answer and that they would answer it on a registration form at the registration place. There are a number of ways that you can implement this, and there's some very good education materials at the website listed here, and will be, you know, these slides will be available to you, and we can also get that website to everybody listed on our portal. So in terms of the workflow of this, you can either think about data input at home through a portal. You can think of it as data that's inputted at, you know, when people register on site, either through a paper form or through a kiosk or tablet or any one of those sort of ways of gathering the data. And people will either report or not report, and you know that information is entered. Or you can be doing it from the provider side, and you know, be having the physician or nurse practitioner or PA entering that data from the into the EMR on that side. I think the thing that is the most important, and one of the things that I would love to see happen with Centricity, is better communication between the practice management side of the house and the EMR side of the house, so that with relative ease, the people in the clinical area knew what the patient was putting into the system on the registration side. So that, because that's where it really matters, right? That's where we want to make sure we're doing the right thing from a cancer screening perspective. That's where we want to make sure we're doing the right thing in terms of getting this patient anything and everything that they need to feel comfortable in our health centers. So getting that information from the front to the mid-office, to the clinical office, is a little bit, it's not as smooth as I would like to see it, and I think that's an area that we really need to work on. So these are the questions. Do you think of yourself as straight or heterosexual, etc., or you choose not to disclose? Then what is your gender identity? And then which sex were you assigned on your original birth certificate? And then finally, what pronoun do you like to use, and what name would you like to use? Centricity does a pretty good job of having that nickname area in the registration screens, and that nickname does come across to the clinical side. If you include it in the banner, you can include it in the banner. So there are ways of getting that piece of it communicated fairly easily, but their answers to those questions, not so much. So this is how the Visualutions looks. There's that you know, sort of preferred name, how somebody wants to be referred to. You need to shell out to the CHC registration area and then to the additional tab to get to the sexual orientation, gender preference, and pronoun preference area in the registration screens. And then Visualutions, also you have to shell out to the Visualution, these are the drop downs for Visualutions. Excuse me for getting confused there. These are the drop downs and how they look. One of the things that needs to be fixed with Viz is they don't have the pronoun they or them as indicated here. And then they also don't have an other area. They've sort of limited that, and that definitely needs to be addressed. In the virtual officeware, again, you are shelling out to the additional, and here's the information. And again, we need to improve those drop downs. So I know that some of the questions have been around how do I implement this at my health center. And I did not go into that level and depth in this particular presentation, but I think it's something that we would be more than happy to work with you guys on in terms of you know, how you might go about implementing and really getting on top of that situation for in your health centers, and where you're going to collect that information, who's going to collect that information, what can some of the dialogue or scripting look like in order to get that information in a reasonable way. So I know we've got about 30 minutes left. It looks like Sherry has a question.
Sherry,
Yeah,
I've
hi,
unmuted you.
It's more of just getting some feedback from people on the SOGI implementation. We're in the process of discussing front office training, how to do it, looking at using possibly Phreesia to actually have the patients enter the information, then have front office actually put it into the VAL module on PM. Right now we're getting the typical feedback from managers as to, oh, our patients are going to leave, they're not going to answer these questions, you know, that sort of thing, yeah. Which I know is typical, you know, when they're first introduced. But just wondering, you know, if people do that from the front office. Then we were also wondering if the answers are not straight, like straight male or straight female. Is anybody documenting it on the clinical side? I mean, I can easily create a form to, you know, that would make providers aware on the chart side, you know, but not for every patient. We're just looking for feedback on what others have done that worked, I guess.
So I don't know if anybody else on the call has had some experience with that this year as they've prepared for the UDS reporting that they needed to do. We'd love to hear from you if you have. But I guess I'd like to clarify, when you say answers that aren't straightforward, can you say more about what you mean by that?
Well, yeah, and I'm trying to word it appropriately. This question was asked to me yesterday when in discussing could we possibly create a form that would only be used in the chart using the observation terms where the answers to the questions weren't straight female or straight male. So if there was any concern with how sexuality would affect the medical care.
So I would imagine that in that case, Sherry, it would actually map to something else. If somebody wasn't straight or lesbian or gay or bisexual, then it would be something else. I mean, the point of this is to give enough information to open a dialogue.
Right, and see, and we get that, but the thing is, if it's collected on the front office side, which you were planning on doing, and then captured in the virtual
right.
QDS,
right.
the providers are never even going to know because they don't look there.
That's exactly right. That's exactly the concern that I have about this. In the way that it's in the way that the data is entered in Centricity, it's a bit of a problem because it doesn't get to the mid-office or the clinical side of life in a way that is actionable data, right? So that's
right, and that's the question.
Right. So if you are going to use Phreesia to do this, for example, and you're going to have people enter it into the practice management system manually anyway off of Phreesia, one of the things you may want to consider is how will Phreesia communicate that to a clinical form.
And that we're actually in the process of looking for that right now, but our understanding is there isn't anything that can link from that side really to the observation terms on the clinic.
Tuned, right, we do have a project here locally in Philly that is started right now, and whether or not we're successful with that, we'll let you know and how that works. But the observation terms should be available. If they're not, we should be requesting them. And
they are. They're there.
Yeah,
but what we're asking is there a way for that from Phreesia to go into an observation term? We didn't think there was.
Well, there should be. And again, I'm not 100% up to speed on what kind of integration Phreesia has at this moment. I'm assuming that you've had that conversation with them.
Well, I think we've asked the question. I don't know that we've got the answer.
Gotcha. Well, to the extent that they bug me almost weekly looking for business. So I don't mind asking the question for the network.
We'll see if the same answers.
Yeah, that would be good to compare answers because often it's not the same.
Yeah.
But I can certainly explore that, and there is another vendor that we are beginning to work with, like I said, in a project locally, but it's just not ready for publication yet. But
okay.
The concept is to be able to use that to screen people for a variety of things and have that information populate on the electronic health record side. But I think we also have to push Viz and we have to push VOW to get that information somehow passing over into the chart.
Okay. Yeah. Yeah, because we don't want to just do it for the sake of doing it. We want it to be clinically valuable.
Right.
You know. So.
Right. Right. And you may want to think about using directives to, and you would need to manually populate the directive. But then once you populate the directive, it will show up on the patient's charts, summary screen.
Oh, okay. Yeah.
It's not elegant, but it might serve. And you may think about so that, you know, it doesn't sort of scream at you. Do you know what I mean? Like you may think of a way to put it in there that would be sensitive. And yeah.
Okay. All right. Thank you.
Okay.
Yep.
So any other questions or areas that you absolutely wanted to see covered that we did not cover that I should include next time? By the time we meet again, I will have gone to the Centricity, the user group conference, and we'll have a little bit more information to share on development trajectories and things of that nature. So to Rebecca's point, they are headed in the area of more HTML forms. That's the way the new orders module is going to work. So, you know, I'll have more information about that soon, but that's in the May timeframe when that conference is about to happen. Is anybody planning to go to CLive, to the Centricity Healthcare User Group Conference in Boston? All right. Well, I can give you some time back today, folks. I really appreciate your attention. If there are no further questions or concerns, then we'll give you time back.
All right, thank you everybody for taking time out of your afternoon to join us for today's call. As I mentioned, the slides and the recording will be available on the portal shortly, and I'll also be sending out a brief SurveyMonkey survey for your feedback on the call this afternoon. So enjoy the rest of your afternoon.
Thanks.